Good morning or good afternoon, everyone. I will be the lecturer for today, and today we will be talking about the endocrine system. So, as highlighted on the screen, these are the different parts of your endocrine system. As compared to last time, our senses and our nervous system, the endocrine is a lot smaller than our nervous system. However, they play the same important role as our nervous system in controlling our body functions. So, our endocrine system relies on chemical messengers. So, these are the principal means by which coordination occurs in the body. This allows cells to communicate with each other to regulate body activities. These are both produced by the nervous system and the endocrine system. So both our CNS and our endocrine system produce the same chemical messengers. So we have different classes of chemical messengers. First, we have our autocrine chemical messengers. These stimulate the cells that originally secreted it and sometimes nearby cells of the same type. So the keyword to look for here is auto, meaning self. So this usually stimulate cells of the same type. Examples of which are your eicosanoids, thromboxanes, prostacyclines, and leukotrienes, and prostaglandins. So these are very important chemical messengers for our immune response and for our inflammation. So our eicosanoids, these are released in response to inflammation. Next, we have our paracrine chemical messengers. These act locally on nearby cells, and usually they act on cells different from the ones that secreted it. So example is somatostatin, histamine, and eicosanoids. So somatostatin, this inhibits insulin secretion. So somatostatin does not inhibit itself, but it inhibits the secretion of insulin. You also have your histamine, which is the primary hormone responsible for the our allergies, released by certain white blood cells during allergic reactions, and it stimulates vasodilation in nearby blood cells. So this is actually what is dangerous about our anaphylactic reactions. So our anaphylactic reactions, these are severe allergic responses. This may be enough to cause inflammation in our lungs so that our patient cannot breathe. Next, we have our neurotransmitters. Neurotransmitters are secreted by neurons that activate an adjacent cell, whether it is another neuron, a muscle cell, or a glandular cell. These are excreted into the synaptic cleft other than the bloodstream, meaning these neurotransmitters do not actually reach the bloodstream, because once they are in the synaptic cleft, they are either taken up by the proper receptor or they are biotransformed back into their original components. So two examples of our of our neurotransmitters is our acetylcholine for our parasympathetic nervous system and our norepinephrine or epinephrine for our sympathetic nervous system. And next, we have our topic for today. We have our endocrine chemical messengers. These are secreted into the bloodstream by certain glands and cells which together constitute our endocrine system. This affects cells that are more distant from their source, meaning a gland from your brain can affect different parts of the body. So this affects cells that are distant from their source, like our thyroid hormones, growth hormones, insulin, and other endocrine hormones. So this is a summary of the different types of classes of chemical messengers. Okay, so we have an overview of the different parts of our endocrine system. These are the primary functions of our endocrine system. 1 is metabolism, 2 is control of food intake and digestion, 3 is tissue development, iron regulation, water balance, heart rate and blood pressure regulation, control of blood glucose and other nutrients, control of reproductive functions, uterine contractions and milk release, and immune system regulation. So what are the characteristics of our endocrine system that makes it unique from our different systems? So what makes it unique is our glands, or our endocrine and exocrine glands. When we say endocrine, it is derived from the Greek words endo, meaning within, and krino, meaning to secrete. So endocrine glands secrete minute amounts of chemical messengers called hormones into the bloodstream. Meaning these hormones are actually maintained inside your body. As opposed to our exocrine glands, meaning outside, this secretes outside the body or any hollow cavity like your stomach. A good example is your gastrine. Okay, so the word hormones is derived from the Greek word hormone, which means to set into motion. It is very fitting for that function. Chemical messengers that are secreted into the blood travels into distant target tissues that bind to specific receptors to produce a coordinated set of events in that target tissues. We have two types of chemical hormones, or two categories. We have lipid-soluble hormones and water-soluble hormones. When we say lipid-soluble hormones, these are non-polar. So these are usually your steroid hormones, thyroid hormones, fatty acid derivative hormones such as certain eicosanoids. They are non-polar, meaning they are oil-soluble and lipid-soluble, and they can freely cross our cell membrane because our cell membrane is made out of a bilipid layer or phospholipid bilayer. So water-soluble hormones are the next type. These are polar molecules. This includes protein hormones, peptide hormones, and most amino acid-derived hormones like your growth hormone, antidiuretic hormone, prolactin, etc. Okay, so how are they different? So we have the lipids on the left and our water-soluble on the right. For our lipid-soluble hormones, they do not actually need any special type of transport process. Because they are already lipid-soluble enough, they can freely cross our cell membrane and act on the nucleus. While for our water-soluble hormone, it needs to pass through certain receptors first before they can be taken up into the cell. Or before they can exert their effects, they must act on something on the lipid or our phospholipid bilayer first, or on the cell membrane. Okay, so this is the general way on how our lipid-soluble hormones react. Okay, so in a nutshell, how do hormones act? Hormones act simply if they reach the cell or reach the target site. First, they must reach the target site. Second, they must bind to the target. Okay, these are usually what you call receptors. And number 3, the bound target must elicit an effect or a change in the cell itself. It may be a different function of the cell. It may also be that the cell will secrete another hormone or any other effect. As long as there is a change in the cell, the hormone was successful. Okay, so transport of lipid-soluble hormones. Because of the small size and low solubility in aqueous fluids, lipid-soluble hormones travel in the bloodstream attached to binding proteins. They are usually bound in the bloodstream. The rate at which lipid-soluble hormones are degraded or eliminated from circulation is greatly reduced once they are bound to our proteins. Lifespans of our bound hormones can last from a few days to as long as several weeks. Without the binding proteins, the lipid-soluble hormones quickly diffuses out of the capillaries and degraded by the enzymes of the liver and lungs, or be removed from the body by the kidneys. For water-soluble hormones, on the other hand, they are freely flowing in the blood. They dissolve directly into the blood and are delivered to their target tissue without attaching to any binding protein. Proteases may degrade protein and peptide hormones in circulation, and then the breakdown products will be excreted in the urine. However, some water-soluble hormones have chemical modifications, such as the addition of a carbohydrate group, which prolongs their lifespan. Okay, so we have three types of stimuli that regulate hormone release. We have our humoral, neural, and hormonal. When we say humoral stimuli, these are blood-borne chemicals. These are circulating chemicals in the blood. It is stimulated by hormones that are sensitive to circulating blood levels of certain molecules, such as glucose, calcium, or sodium. Okay, so the effect of the humoral stimuli stem out of detection of these compounds in the blood. So the humoral stimuli originates from detection of chemicals in the blood. Next, you have your neural stimuli. So these are secreted due to direct response to action potentials in the neurons as occurring during stress or exercise. So in response to stimuli such as stress or exercise, the sympathetic division of our nervous system stimulates the adrenal gland to produce norepinephrine and epinephrine, which help the body respond to stimuli. Hormones from the hypothalamus that cause the release of other hormones are called releasing hormones. So later we will be discussing the different types of hormones and what they do. And lastly, we have our hormonal stimuli. These occur when a hormone is secreted and stimulates secretion of other hormones. So most of these come from the anterior pituitary gland. So we have our tropic hormones from the anterior pituitary gland that stimulate hormones from other endocrine glands. Okay, so this is the diagram of how stimulatory hormones work. So for example, our hypothalamus will releasing hormones to our anterior pituitary. So the main job of the anterior pituitary is to release hormones that affect our endocrine cells, leading to, again, to send out different hormones to affect our target cells. Okay, so hormones may stimulate other cells to produce other hormones. So how are the inhibition of hormone release performed? Obviously, we cannot continuously secrete hormones, since anything that is excessive will have a detrimental effect. So although the stimulus of the hormone secretion is important, inhibition is equally important. Humoral substances can inhibit the secretion of hormones, like in some cases, example is our blood glucose. If our blood glucose is too low, it will cause glucagon to act. If it's too high, it will cause insulin to act. Neural stimuli can also prevent hormone secretion, and hormonal stimuli can prevent hormone release. So inhibiting hormones, these are hormones from the hypothalamus that prevent the secretion of tropic hormones from the pituitary gland. Next is the regulation of hormone levels in the blood. So two processes regulate the overall blood levels of hormones. We have the positive feedback and the negative feedback. Let's talk about the negative feedback first, since it is simpler to discuss. So negative feedback prevents further hormone secretions once a set point is achieved, meaning it is a self-limiting system. So an example is your thyroid hormones inhibit the secretion of other releasing hormones from the hypothalamus and their tropic hormone from the anterior pituitary. Meaning, so there's hormones that cause the release of thyroid hormones. If there is too much thyroid hormones, it will now trigger the stopping of the release of the hormones that produce thyroid hormone. Okay? Meaning, if it reaches a certain point, it will now enact a way to stop more of that hormone. On the other hand, we have our positive feedback. So it is a self-promoting system whereby stimulation of the hormone secretion increases over time. It is a self-propagating system. So examples of this is for your estrogen stimulation. Prolonged estrogen stimulation promotes release of more anterior pituitary hormones responsible for stimulating ovulation. Okay, so you will be discussing this in your reproductive system for women. Okay, so we have negative feedback and positive feedback on the screen. So example is this: your anterior pituitary will release a tropic hormone which will trigger the release of the intended acting hormone. If there is too much of the intended target hormone, this one, it will now send a sign to the originator to stop producing our stimulating hormone. And it will now stop the process, and the cells producing the next hormone will stop also producing, leading to a decreasing amount of hormones in the body. Positive feedback, on the other hand, is the opposite. So you have your tropic hormone that targets the endocrine cells. The target endocrine cells will release the hormones, and more of the hormones will actually cause more production of tropic hormones, meaning it is a cycle. Okay, so how do hormone receptors and mechanisms of actions? So how do hormone receptors act? So hormones exert their actions by binding to proteins called receptors. So receptor is a chemical group or molecule on the cell surface or in the cell interior that has an affinity for the special chemical group or molecule. The receptor site is the portion of each receptor molecule where a hormone binds. Okay, so the shape is predetermined already. There is what we call specificity. There is a tendency for each type of hormone to bind to only one type of receptor and not to others. This is actually called your lock and key model. So if your hormone is shaped like a triangle, the receptor should actually fit that shape. If your receptor does not fit that shape, this will bind, but this will not. Okay, that is called the lock and key model. And it states that hormones or drugs can only bind to receptors that have specific shapes that can accommodate binding of that drug or hormone. So there is specificity. Okay. However, some hormones such as epinephrine can bind to a family of receptors that are structurally similar. So examples of which is your epinephrine, norepinephrine, your other alpha receptor agonists. So once you go into pharmacology, this we will go deeper once you reach pharmacology. Okay, so this is the lock and key model. So how does binding work? So hormones are secreted by endocrine glands. They travel to the bloodstream. Once it travels to the bloodstream, it will travel to all parts of the body. And hormones bind to receptor sites and lock to target tissue, and the response occurs. Okay, you might be wondering, how can the hormone know where it should go? But the simple answer is, it does not. Hormones are chemicals. They do not have a brain. They do not think. But the key word here is it travels to all parts of the body. So for a hormone to reach a certain receptor, it actually travels throughout the body and eventually it will go to that target receptor. However, due to specificity, if it is not at the needed place, example, you release norepinephrine, and norepinephrine does not actually go directly to the receptors. It will flow through your body. You can have certain amounts of epinephrine in your toes, in your scalp, in your arms, but it will not do anything. Why? It's because there is no receptors for epinephrine there. Well, to be specific, small blood vessels have receptors for epinephrine, but that's beside the point. Meaning, it will not act if it is not bound to the receptor. It goes the same with drugs. Drugs also act the same with hormones. If it's not in the proper receptor, it will not act. Okay? So if it reaches the proper receptor, example, the hormone reaches its intended target organ, it will now elicit a response. It will bind to the cell, it will bind to the receptor, and there will be a change that will occur in the cell, and the cell will give its intended activity. So how do hormones cause change? They alter cell activity of target tissues by increasing or decreasing a cell's normal processes. They can also change permeability of the cell membrane by opening or closing ion channels. They can also change or push the cell to synthesize proteins. Okay, so we have different classes of receptors. We have lipid-soluble hormones that bind to nuclear receptors, and we have water-soluble hormones that bind to membrane-bound receptors. Okay? So first, we have our lipid-soluble hormones. They directly bind to nuclear receptors. It is inside the nucleus because they are already lipid-soluble. They can freely enter the cell. They do not need to pass through any other systems. Water-soluble hormones, on the other hand, do have difficulty in entering the cell. That is why instead of going directly to the nucleus, they bind to receptors found on the cell membrane instead. Okay? So this is again the difference between our lipid-soluble hormone and our water-soluble hormone. Next, we have the action of nuclear receptors. Nuclear receptors have portions that allow them to bind to the DNA in the nucleus once the hormone is bound. The hormone receptor complex activates genes which activate the DNA to produce mRNA. Once the mRNA is produced, it will now increase the synthesis of certain proteins. Nuclear receptors cannot respond immediately because it takes time to produce the effect. Okay? So nuclear receptors, these are special receptors inside the cell in which if they are activated, there will be a change in the production of the normal proteins. So once they are activated, it will synthesize a new protein. Okay? That is why drugs that act this way usually do not act immediately. Okay? So a good example of this is your cortisol or cortisone. So if ever you've taken hydrocortisone or methylprednisolone, prednisone, these are steroid type drugs that directly interact with the nuclear receptors. That is why the effect of anti-inflammation is not immediate compared to your NSAIDs, like your mefenamic acid. Membrane-bound receptors, on the other hand, they activate a cascade of events once the hormone binds. Some membrane-bound proteins are associated with the membrane proteins called G proteins. When a hormone binds to a membrane-bound receptor, G proteins are activated. The alpha subunit of the G protein can bind to ion channels and cause them to open or change the rate of synthesis of intracellular mediators like your CAMP. Secondary messenger systems act rapidly because they act on already existing enzymes and produce an amplification effect. As compared or contrasted to our nuclear receptors, membrane-bound receptors are much faster because the receptors the messengers are already present. They are just inactivated. So instead of making new proteins, you just have to activate different pathways. Okay, so now let's talk about the endocrine glands and their specific hormones. So the endocrine gland consists of ductless glands. Some of the glands of the endocrine system perform more than one function. Okay, so they could be multi-role. So this is your hypothalamus and your pituitary gland. Okay, so I have your hypothalamus, the infundibulum. The infundibulum actually connects the hypothalamus and your pituitary gland. And you have your sella turcica, which holds your pituitary gland. So you have your pituitary gland, also called your hypophysis. It is suspended in the hypothalamus by a structure called infundibulum. So this is the bridge. It is known as the body's master gland since it controls the function of many other glands. It has two parts. You have your posterior and anterior pituitary. It is also called your adenohypophysis, and your posterior pituitary is your neurohypophysis. So your anterior pituitary or your adenohypophysis is made out of epithelial cells derived from the embryonic oral cavity. It consists of these parts right here. Your posterior pituitary, on the other hand, is the extension of the brain and composed of nerve cells. This consists of these parts here. Okay, so your pituitary gland is very small. Okay, so here on the screen, there is a summary of the different hormones secreted by your pituitary gland. So your posterior pituitary gland only produces two, your antidiuretic hormone and your oxytocin, while your anterior pituitary gland produces a much wider range of your hormones. So let's start with the anterior pituitary gland. The pituitary gland releases hormones such as the growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, luteinizing hormone, follicle stimulating hormone, prolactin, and melanocyte stimulating hormone. So please take note, class, of the abbreviations of each hormone. They might be asked in your quiz. Okay? So you must know what are the abbreviations of each hormone. Okay, so this is how it works. So if you have stimulus from the nervous system, it will secrete releasing or inhibiting hormones. Once it is received by your hypothalamic pituitary portal system, it will now cause the cells inside your pituitary to release the appropriate hormone. So let's talk about each type of hormone. First, you have your growth hormone. Its target tissues is smooth tissues. What do you think it does? Correct. It promotes growth. So it stimulates growth of bones, muscles, and organs by increasing gene expression. Okay? So primarily, it actually stimulates muscles, and it stimulates growth of bones, specifically lateral growth of bones before your bones or before the cap of the bones form. So children usually have large amounts of growth hormones, especially once they reach their adolescent period. That's why we have what we call the growth spurts. So some abnormalities regarding growth hormone: if you have too much or too little, it will lead to gigantism and dwarfism. So too much causes gigantism and too little causes pituitary dwarfism. So secretion of growth hormone is controlled by hormones from the hypothalamus. A releasing hormone stimulates growth, and an inhibiting hormone inhibits its secretion. Most people have a rhythm of GH secretion which peak after deep sleep. Okay, so if you're going to ask me as a pharmacist, if you take growth hormone, will you grow taller at your age? Probably not, because your bones have already sealed. You will not grow any further. However, it will promote growth of your muscles. So if you are a bodybuilder or a athlete, this is probably banned in your sport. Next, you have your thyroid stimulating hormone. The primary target is your thyroid gland. So it secretes thyroid hormones T3 and T4. Thyroid stimulation does not act as thyroid hormones. It only causes the thyroid to stimulate to produce thyroid hormones. So if you have abnormalities with your TSH, too much TSH can cause enlargement of the thyroid and cause too much thyroid hormone secretion. Too little will cause the thyroid hormone to shrink, and too little thyroid hormone secretion. Okay. Next, you have your adrenocorticotropic hormone, or your ACTH. Its primary target is your adrenal cortex. Its main function is to release to cause secretion of glucocorticoid hormones, such as your cortisol or your hydrocortisone. So the ACTH molecules bind to melanocytes and increase skin pigmentation as well. And darkening of the skin is one symptom of too much adrenocorticotropic hormone secretion. Next, you have your gonadotropins. So these are primarily hormones that regulate your sex hormones. These are hormones that bind to membrane-bound receptors on the cells of the gonads, like your ovaries and testes. These regulate the growth, development, and functions of the gonads. So we have different types. We have our luteinizing hormone for females. The target organ is our ovaries, and the function is to promote ovulations of oocytes and the secretion of sex hormones such as your estrogen and progesterone. However, for males, LH causes sperm cell production and promotes testosterone synthesis. Next, you have your follicle-stimulating hormone for females. The target is your follicle in your ovaries. It promotes follicle maturation and estrogen secretion, primarily for the preparation of pregnancy. For males, on the other hand, its target tissues is your seminiferous tubes in your testes, and it also promotes sperm cell production. So if you have no absence of luteinizing hormone or follicle stimulation hormone, ovaries and the testes will decrease in size, no longer produce oocytes, and no longer secrete hormone. So this is very, if you encounter this problem, you have a very large problem on your hands. Next is your prolactin. Pro meaning increases, lactin, imagine breast milk. Target tissues is mammary glands and your ovaries. It helps promote development of breasts during pregnancy, so lumalaki, and it also stimulates the production of milk following pregnancy. Okay. Please do take note that sometimes males can also produce milk. However, these are usually disorders of the CNS in which prolactin-like substances are excessively produced in males, which cause them to lactate. Next, you have your melanocyte-stimulating hormone. So the target is the melanocytes in your skin. It increases melanin production, and the MSH structure is similar to ACTH structure, and over secretion of either hormone causes the skin to darken. Okay, so this is a good example of what we talked about earlier about how about a family of hormones can cause similar effects. Next, you have your posterior pituitary gland. So you only have two hormones here, your antidiuretic hormone or your vasopressin and your oxytocin. So your ADH targets is the kidneys. Antidiuretic meaning it prevents your diuresis. Functions include increased water reabsorption of the kidney tubules and also conserves water. Reduced ADH released from the posterior pituitary results in large amounts of dilute urine. Okay. And a side effect of diabetes insipidus can cause a large amount of dilute urine due to lack of ADH secretion. It can lead to dehydration and thirst. Next, you have your oxytocin. The target is your uterus. It increases uterine contractions during labor. It also targets your mammary gland and it increases milk letdown from the breasts. It stimulates the milk down reflex. Okay, so the action is similar to your anterior pituitary. Next, you have your thyroid gland. Your thyroid gland is one of the largest endocrine glands. It is found in your neck. It is made out of two lobes connected by a narrow band called your isthmus. Lobes are located on each side of the trachea, just inferior to the larynx or your voice box. It is consisting of your follicular cells. The main cells are main producers of hormones. You also have your parafollicular cells. These are cells that support the follicular cells. And you require iodine to synthesize thyroid hormones. These cells in your thyroid gland secretes thyroid hormones, and the target tissues is most of the body. Your thyroid hormones are primarily T3 and T4. So the main function of your thyroid hormone is to regulate the metabolic rates of your body, also essential for growth and development. So this is your thyroid gland. It's found below the larynx. Okay, so these are the two lobes of your thyroid hormone, and this narrow band here is your isthmus. So this is the name of your T3 and T4. T3 is your triiodothyronine, and T4 is thyroxine or tetraiodothyronine. Okay. So, please focus on the next part. Abnormalities in our thyroid gland is very common, especially in women. So, knowing this common signs will help you decide in the future, if you're a doctor, what is the probable disease. So, for hypothyroidism, it is a lack of thyroid hormones. You lack T3 and T4. Okay, it is very simple to treat. Simply give T3 and T4 in your capsule or tablet form. Hyperthyroidism, on the other hand, results in an elevated thyroid hormone secretion. You have too much of T3 and T4. Okay, so on the screen is the comparisons of hypothyroidism and hyperthyroidism. What is easy here is they are totally opposite effects. So if you memorized only hypothyroidism, simply reverse the effect and you will have the effect for hyperthyroidism. So for hypothyroidism, decreased metabolism, you have weight gain, reduced appetite, and fatigue. You have low temperature and pulse or coldness. You have cold, clammy skin, myxedema in adults, and cretinism in infants. For hyperthyroidism, you have increased metabolism. You have weight loss due to the increased metabolism. You also have an increased appetite nervousness due to hyperactivity due to hyperthyroidism. It will lead to higher temperatures and pulse. Usually, these are related to your blood pressure. Pulse is related to blood pressure. So, it will give you a warm, flushed skin and usually is caused by Graves' disease. Cretinism is characterized by mental retardation, short stature, and abnormally formed skeletal structure. Myxedema is the accumulation of fluid and other molecules in the subcutaneous tissues. Graves' disease is a type of hyperthyroidism that results when the immune system produces abnormal amounts of proteins called your TSI. Why is it written here? Okay, you produce TSI. TSI is thyroid stimulating immunoglobulin. So this is an immunoglobulin. So it is not actually a thyroid hormone. It's an immunoglobulin. However, it is shaped closely enough that it can bind to TSH receptors. And if you have something that binds to TSH receptors, this will cause release of T3 and T4. Okay, the may often accompanied by bulging of the eyes, a condition called exophthalmia. Okay, so this is how T3 and T4 is regulated. Primarily, T3 and T4 will regulate itself. If your thyroid detects, if your body detects that you have too much T3 and T4, it will actually stop the production of T3 and T4 by inhibiting TSH release. No TSH, no thyroid hormone production. Next is your calcitonin. It is also produced in your thyroid. It is responsible for calcium. So calcitonin is secreted if too much calcium is present in the body, and it causes calcium levels to decrease to their normal ranges. So this is how your body compensates for large amounts of calcium in the body. Target tissues is the bones. The effect is it decreases calcium levels by decreasing rate of bone breakdown. Okay, so your bones is actually a source of calcium. Okay, so to reiterate, your calcium is actually sourced from your bones. So your bones is a good source of calcium. So your bones is broken down by cells called your osteoclasts, which primarily breaks down bones into calcium, usable calcium. So what calcitonin does is it decreases the rates of osteoclasts, leading to lessened bone breakdown, leading to less calcium levels in the blood. Next, you have your parathyroid glands. Parathyroid glands are found on the posterior sides of the thyroid. These are usually small black glands in your parathyroid glands. So these are located in the posterior wall of the thyroid gland. These are divided into the following: chief cells, which are the main producers of hormones. You also have your oxyphil cells, which back up or support the cells. You secrete parathyroid hormone. This, you can think of it as the opposite of your calcitonin. The target tissues is your bones and kidneys. It causes blood calcium levels to rise, and it increases the rate of bone breakdown by osteoclasts. This is primarily the reverse of our calcitonin. Okay, so you can see parathyroid glands having a different color. Okay, so you have your magnification of the different cells. Okay, so your body will compensate reflexively depending on the levels of your calcium. So if you have, okay, let's start with the one on top. Okay, if you have too much calcium in the blood, what will the body do? It will stimulate calcitonin release. Okay, it will release calcitonin and will also decrease parathyroid secretion. What is the effect? Bone breakdown is decreased. Once bone breakdown is decreased, also uptake of calcium in the intestine is decreased. It will now lessen the calcium in the bloodstream, and it will return to the normal levels. Okay, if you have too few calcium or mababa ang calcium nyo, the opposite of the one on top will happen. Your calcitonin will decrease and parathyroid hormone will increase. What will happen? Increased calcium absorption from the intestine, and you will have increased breakdown of bones by your osteoclasts, leading to a higher level of calcium in your blood, and you will now return to your normal calcium levels. Next, you have your adrenal glands, also called your suprarenal glands because they are superior part of each kidney. We have two major parts, your adrenal medulla and your adrenal cortex. So the medulla is the innermost layer while the cortex is outermore. Your cortical layers are divided into zona glomerulosa, zona fasciculata, and zona reticularis. Please read on what hormones are secreted by each. So you have your adrenal glands here on the screen. As you can see, they are on top of the kidneys. They are shaped like a little cap. Okay, so this is your adrenals. Okay, this is a illustration of the cortex and medulla. Okay, so on the top you have your capsules. Capsule. Okay, and on the suprarenal cortex, you have your three zones: zona glomerulosa, zona fasciculata, and zona reticularis. On the bottom, you have your suprarenal medulla, or the innermost, or your adrenal medulla. So what are the roles of your adrenal glands? So for the adrenal medulla, it secretes mostly epinephrine and norepinephrine. Okay, so these are referred to as your fight or flight hormones. So secretion is the response of stimulation by the body to stress, particularly from our sympathetic nervous system. So the target tissues is primarily your heart, blood vessels, liver, and fat cells. The primary function of your adrenal hormones, or epinephrine or epinephrine, is to prepare you to fight or to flight. Meaning it's either you use your muscles to run away or you use your muscles to fight. Okay, so in summary, this is the major effects of your epinephrine. Okay, so let's make it easy. Okay, your fight or flight response is designed to keep you alive. Okay, so in stressful situations, your body will prepare itself to fight or to run away. So in preparation, what do you need? You need a lot of energy. Where will you get this energy? It increases glucose release from the liver. It will also increase release of fatty acids. Okay, so you have your energy. Next, for extraneous activities like muscle usage, you need oxygen. Oxygen is carried by the blood. So you need to have a good blood flow for your fight or flight response. Okay, to have a good blood flow, you need to increase heart rate. More heart pumps, more blood flowing, more oxygen. Okay, and it doesn't end with increased heart rate. Your body will actually decrease the blood flow to non-essential organs. So if ever you're in a life or death situation, your body will not prioritize giving blood to your digestive system or to systems that are not necessary at the moment. So it will decrease blood flow of the internal organs and the skin. You do not need to cool off right now. It will increase blood flow to skeletal muscles, which you will be using. It will also decrease function of the visceral organs. You do not need to digest right now. You need to run away or to fight. It also increases blood pressure, and it also increases metabolic rate of the skeletal muscle. So this is your survival mode of the body. Next, you have your adrenal cortex. It secretes 3 classes of steroid hormones. When we say steroid hormones, this refers to a certain structure. Or our steroid structure. So it actually looks like... I'm not gonna draw it. Maybe I'll make a mistake. But it generally looks like this. Sorry. It generally looks like this. You have a 24 carbon molecule. Yep, something like this. This is your steroid backbone, made out of 24 carbons. And depending what is attached, that is your specific steroid. Okay, so it is divided into 3. You have your mineralocorticoids, glucocorticoids, and your androgens. The major mineralocorticoid is your aldosterone. It is the major hormone of mineralocorticoids. Its target tissues is your kidneys, to a lesser degree, the intestine and sweat glands. The primary function of your aldosterone is it causes sodium and water to be retained in the body, increasing the rate of potassium excretion. Okay, so it actually leads to sodium and water to be retained in the body. This will actually give an effect in your blood by increasing blood pressure. Okay, changing in blood pressure indirectly affects the rate of aldosterone secretion. So, what happens actually is your kidneys receive 40% of your blood flow. If your kidneys detect that blood flow is decreased, magtatampo yan. No? Sasabihin niya, kulang blood flow ko. If your kidneys have a decreased blood flow, it will now secrete aldosterone. Aldosterone will in kind increase blood pressure by producing a protein called renin from the kidneys. Renin, which acts as an enzyme, causes blood protein called angiotensin to be converted to angiotensin 1. Angiotensin converting enzyme causes angiotensin 1 to be converted to angiotensin 2. Angiotensin 2 causes smooth muscle in the blood vessels to constrict, act on the adrenal cortex to increase aldosterone secretion, leading to increase in blood volume. Okay. Blood vessel constriction and increased blood volume help raise blood pressure. Okay. Actually, aldosterone is just a side effect of the angiotensin cascade. It is only produced when angiotensin 2 is produced. So angiotensin 2 actually causes aldosterone to be released. Okay, once it is released, it acts on the kidneys. Okay, let's reiterate pharmacy style. Okay, renin, angiotensin 1, angiotensin 2. Okay, so renin will cause the release of angiotensin 1. Angiotensin 1 needs to be converted to angiotensin 2. Angiotensin will give off or make aldosterone appear. Okay, and angiotensin 2 has actually constrictive abilities. It causes constriction in other parts of the body. Okay, so an interesting one is angiotensin 1 is converted to angiotensin 2 by your angio converting enzyme or your ACE. Okay, let's talk about drugs since we're here already. If you ever heard of ACE inhibitors, these are your Prils, captopril, lisinopril. Okay, so these drugs act by blocking this enzyme here. If you do not have this enzyme here, angiotensin will not be converted to angiotensin 2. If you do not have angiotensin 2, aldosterone will not appear. Constrictive effects will not appear as well. Therefore, blood pressure decreases. Okay, and you also have your angiotensin receptor blockers or your ARBs. These are example is your losartan. Okay, it blocks angiotensin from binding to anywhere, preventing the effect of angiotensin. Also leads to decrease in blood pressure. Okay, so it got sidetracked. Okay, so you can read this. However, you just simply need to read again. Next, you have your cortisol. Cortisol is the major hormone of your glucocorticoids. The target tissues is most tissues, primarily the fat skeletal muscles. Functions, it increases fat and protein breakdown. It reduces inflammatory and immune responses. So cortisone is a closely related steroid often given to reduce inflammation caused by injuries. This can also reduce the immune and inflammatory responses that result from allergic reactions or abnormal immune responses such as rheumatoid arthritis or asthma. So hydrocortisone or cortisone, methylprednisolone, these drugs, they have a wide variety of use. Primarily, they are used as your anti-inflammatories. However, the trade-off of using this as your anti-inflammatories is it can also cause decreased immune response. Meaning, people who are taking hydrocortisone are more at risk for bacterial infection. Okay. However, you can, if you want to use cortisol as an anti-inflammatory, you can, just not at excessive periods of time. If you want it to be used as an immunosuppressor for rheumatoid arthritis or asthma, you can also do so. However, it comes with a trade-off of increased infections. Okay, so this is how it works. Next, you have your androgens. Okay, so these are most tissues. The function is to stimulate the development of male and female sexual characteristics. For females, it influences sex drive. Okay, abnormally high secretions from the adrenal cortex may result in exaggerated female and male characteristics. Okay, so this is some images. Okay, please take note of this right here. Okay, this right here, please take note. Okay, take note. Pancreas, let's talk about the little yellow thing inside your GI tract. Your pancreas, it is located in your small intestine, also called as your heterocrine gland. Okay, so it's an exocrine gland. It is producing pancreatic enzymes by acinar cells. So these enzymes are actually to be pumped inside your GI tract. It is also an endocrine gland which consists of the pancreatic islets, also called your islets of Langerhans. These secrete your insulin, glucagon, and somatostatin. So alpha cells secrete glucagon, beta cells secrete insulin, and delta cells secrete somatostatin. Okay, your pancreas is located here near your small intestine, right here. It looks like you know what it looks like. Okay, so it is divided into the head, the neck, the body, and the tail. It looks like a large sperm. Some more images for our pancreas. Radiographic image of the pancreas. Okay, so this is the breakdown of, the of your pancreas. Okay. Your pancreas has specific cells called your islet cells, in which they produce endocrine hormones. So your alpha cells produces glucagon, your beta cells produces insulin, and nasan yung ating delta cells produce your somatostatin. Okay, insulin. It is released from the beta cells primarily in response to elevated blood glucose levels and increased parasympathetic stimulation in association with digestion of a meal. The target tissues is your liver, skeletal muscle, and adipose tissue. So these are very important. So insulin is regulate blood glucose levels. After a meal, glucose levels are high, insulin is released. Insulin will make it so that glucose is stored inside your cells. So abnormalities with your insulin, we have diabetes. You might be familiar with diabetes. Diabetes is a condition in which your body cannot maintain its proper blood glucose levels. We have two types. We have diabetes mellitus type 1 and type 2. So to be very short, type 1 is due to decreased insulin release. Decreased or no insulin release. It is also called your insulin-dependent diabetes. Okay, meaning the body cannot release or produce insulin. You need insulin to live. That is why it is insulin-dependent diabetes. Type 2 is your adult onset or non-insulin-dependent diabetes. It primarily results from aging and decreased insulin sensitivity. Your body can produce insulin. However, it is not enough to maintain proper blood glucose levels. That is why it is called your non-insulin dependent diabetes. However, please do not be surprised that if type 2 DM becomes severe enough, it will also need insulin to be injected. Next, you have your glucagon. Your target tissues is the liver. The primary function is to regulate blood glucose levels secreted when blood glucose levels are low. It causes glycogen to be stored in the liver to be converted into glucose, which in turn is released to the blood to increase blood glucose levels. So the primary goal of your glucagon is to release blood glucose. Okay, and you have your somatostatin. It inhibits secretion of insulin and glucagon, also inhibits gastric tract activity. It is more, it's not primarily used with insulin and glucagon, but however, it is more used with gastric tract activity, like in cases of irritable bowel syndrome and inflammatory bowel disease. Okay, so again, we have this chart right here. If you have abnormal glucose levels, it will go into opposite directions on which way is appropriate. If you have too much blood glucose levels, the blood glucose levels is too high, you will now produce insulin. When insulin is produced, your muscles will take them up, take in glucose. In the liver, you will produce glycogen. It will store glucose as glycogen, decreasing the sugar in the blood, eventually going down. If you are now too low in sugar or blood glucose, glucagon will be secreted. Glucagon will cause release of glucose in the muscle and also cause breakdown of glycogen, increasing blood glucose levels. Okay, so what is the antidote to too much insulin? Glucagon or dextrose, sugar. Next, you have your testes, or the male reproductive organ of the male. It is glands found in the scrotum. It produces sperm cells and secretes testosterone. Testosterone is found or acts on most tissues and is primarily responsible for growth and development of the male reproductive structures. muscle enlargement, growth of body hair, voice changes, and the male sex drive. Also aids in sperm cell production. Ovaries, on the other hand, is for women. It secretes or produces estrogen and progesterone. Target tissues is similar, most tissues, and the function is to aid in uterine and mammary gland development and function, external genitalia structures, secondary sexual characteristics, sexual behavior, and the menstrual cycle. You can find them here. Thymus. Your thymus lies in the upper part of your thoracic cavity. It is present at birth until puberty but degenerates through childhood. It is the maturation site of T cells, which is for your immune response. It is important in the function of the immune system. It is most important early in life. If an infant is born without a thymus, the immune system does not develop normally and the body is less capable of fighting infections. So this is your thymus. Oh. Okay. So as you compare, the thymus in adults is smaller than the thymus in infants. Okay. If you haven't noticed now, these are actual humans that are carved up. Thymosin is produced by your thymus. It is a hormone and primarily targets your immune system tissues. It aids in the development of white blood cells called T cells. T cells help protect the body against infection by foreign organisms. It promotes immune system development and function. Next, you have your pineal gland, also known as the pineal body or epiphysis cerebri, a small pine cone-shaped structure located at the superior and posterior to the thalamus of the brain. It primarily secretes melatonin, and the target tissue is your hypothalamus. Your hypothalamus, once affected by melatonin, inhibits secretion of gonadotropin, releasing hormones, inhibiting the functions of the reproductive system. It plays an important part in the onset of puberty in humans. Also, melatonin is connected with your sleep and wake cycles. The production is inhibited during the day and increased during the night. And it also induces physiological changes that promote sleep, such as decreased body temperature and decreased respiration rate. You actually have melatonin capsules. However, do not actually take them because they are a waste of your money. They do not work due to the nature of it being oral and it is being destroyed before you can even absorb the hormone. Other hormones are your prostaglandins. This cause relaxation of the smooth muscle, such as dilation of blood vessels. Other cause contraction of the smooth muscles, such as contraction of the uterus during the delivery of a baby. Because of their action on the uterus, this has been used medically to initiate abortion. This also plays a role in inflammation released by damaged tissues and cause blood vessel dilation, localized swelling, and pain. Prostaglandins are produced by platelets, appear to be necessary for normal blood clotting. Erythropoietin is a special hormone that acts in your bone marrow. It will promote production of red blood cells. It is primarily produced when the kidneys detect a decreased oxygen level. What I said earlier, your kidneys are very prima donna. They demand a lot of oxygen. You also have your HCG or your human chorionic gonadotropin. So this is together with estrogen and progesterone. This maintains pregnancy and stimulates breast development in pregnant women. So if you have HCG in your urine, congratulations, you are now pregnant. Some other organs with some endocrine function, you have it right here. Okay. So effects of aging in the endocrine system. Age-related changes includes gradual decreases in growth hormone, particularly with people who do not exercise. Melatonin, thyroid hormones, reproductive hormones, and thymosins. Parathyroid hormones increase if vitamin D and calcium levels decrease. And there is an increase in type 2 diabetes in people with a familial tendency. So that is it for the lecture. Okay, so if you watched this far, if you really watched this far, I will be making a list of things you should read. Okay. Number 1, you should read the diseases. You should read the diseases in the book, how they are, the diseases of the endocrine system. Read them, if how they affect, what are the different symptoms, and what are they called. Number 2, know where the hormones originate from. Three, you should also know each hormone. There are lots of hormones that are not discussed in the slides. You can find them in your book, particularly this is in table form. So you should read them. Okay? Next also is hyperthyroidism versus hypothyroidism. 5, effects of insulin and glucagon. Next is the different types of responses, positive and negative feedback. Number 7, comparison of your nervous system versus your endocrine system. So this is actually in the initial pages of the endocrine system. So primarily what I want you to do is read your damn book. Okay, good luck.